For the next session, may I please take the honor to invite Dr. Hari Kumar Nair, Dr. Manav Vadhavan, and Dr. Amit Mandot to please chair this session. The speaker for this session will be Dr. Sanjeev Sehgal. Sir is the Principal and Director Head, Department of Gastroenterology, Hepatology, Max Super Speciality Hospital, Delhi.
I think Dr. Saigal needs no introduction. He is one of the pioneer transplant hepatologists of the country, currently with the Max Super Speciality Group, Delhi. So over to you, Dr. Saigal.
Thank you very much, and thanks Ajay and the team. It's a delight to be speaking on this topic. This is a lecture originally by Dr. Subhash Gupta, and I'm delighted to deliver this talk. I'm pretty much comfortable in this. I mean, I've just seen the slides in the morning, but we have been together for almost 25 years now, and we have worked at various stages in our career together. And right now, me and Subhash, we work together, lead the team Max Hospital. And so I would present exactly the slides which have been originally made by Dr. Gupta. Whenever you find me uncomfortable in a slide, you can understand that I don't agree to that. So this is a very interesting, topic of liver transplant for MASLD. I think this is a thing which we are seeing more and more, and a general, trend that you would see that liver transplant per se has, increased substantially in our country, and this is just a journey of the liver transplant team, which I'm attached to. So we are doing a lot of transplants, and MASH has become among the top three causes for transplant the patients have today. So I'm going to speak on why liver transplant of MASH is different, comorbidities, liver cancer, HCC, certain specific issues like delays, cadaveric versus DDLT, surgical challenges, immunosuppression, and so on. Now, MASLD is different from alcohol liver disease. They are the top two indications, in my opinion, today. Alcoholics often have a transplant which is much more early, whereas in MASLD, sometimes it gets delayed, the urgency is not there, and therefore, like they just go on and on. But the fact is that MASLD, there is a constellation of complications, metabolic syndrome, comorbidities, and so on. Typically, obesity, lipids, hypertension, so on, chronic kidney disease. They are obese, but they still have sarcopenia. That's the important point. They are actually obese sarcopenic patients, and nearly 30 to 50% would have some cardiovascular problem along with. And all these comorbidities substantially impact the outcome of liver transplantation, poor respiratory reserve. They may need, may have obstructive sleep apnea. Diabetes may worsen during their course, both the pre-transplant and post-transplant period. And it's very important that a proper team is there to manage these patients. We often are in close concert with our internal medicine, the endocrinologist. But today I believe that, as Manav has been speaking earlier in a couple of lectures, that all hepatologists should have a strong knowledge of and diabetes management, which is a very integral part, and it's something which we should know very, very astutely, because that is what we are going to be facing day in and day out. Now, renal impairment is very important in these patients. Often they have chronic kidney disease, their GFR is low sometimes. Also, please note that these patients who have MASLD, who have come to us for liver transplant, are actually elderly. Their age is usually 50s, 60s. So, therefore, CKD is more in these patients. Now, some centers would recommend doing a combined liver kidney. It's a very difficult option, especially in these elderly patients who have got other comorbidities, diabetes, hypertension, vascular disease, and so on. And there is always a discussion whether you can do combined or sequential, but I think that's something is a different discussion. But the fact is that we have to be very careful in our peri-op and post-op period so that we minimize the renal toxicity. Cardiovascular events, well, they are again the most common cause of morbidity, and actually this has to be taken care of very, very carefully. we have to be careful about assessing these patients, the cardiac status, when to do their stress thallium, is their cardiac evaluation different from an average patient waiting for liver transplant, when to do angiography, is stenting needed or not. These are all very difficult questions to answer, not so easy, because we know that I mean, it's easier said, but I have seen many patients who have undergone stenting and we do PTCA. They have to be on dual antiplatelets, so we change that. There's a specific protocol which we follow. We are able to do it, after 4 weeks of stenting, but yes, we have to be very careful. And you would find some of these patients having cirrhotic cardiomyopathy. So the incidence of MACE, which is major cardiovascular events, is more in these patients following liver transplant. Now, as we come to the lung part, pulmonary, yes, is different. Yes, this is actually different from the rest of the transplant patients. These patients who have got MASLD have often obesity, hyperventilation syndrome, they have OSA, they may have restrictive pulmonary disease, PH may be more common. And so, therefore, we have to be careful in these patients. We may need to do their cardiac cath, right heart studies more often, and then go accordingly. The point which I was trying to make earlier is that although they are obese, there is a significant component of sarcopenia in these patients. There's also a phenotype called, thin outside, fat inside, the TOFI phenotype, and we all have encountered such patients in our practice. Those who are obese and frail, sarcopenic, it's really very difficult to improve them in the pre-transplant period. And for pure obesity, there were various protocols for doing a intra gastric balloon, sleeve gastrectomy, and so on. Now the newer drugs maybe they may be of use. I don't know. None of them are actually of use in those who are child B, child C cirrhotics, where we cannot use them. So bottom line is that in these patients, handling their obesity, BMI 40 plus, muscle wasted situation is a very, very ominous thing. Leads to poor performance status in these patients and more complications in the post-transplant period. Somehow they also have higher neurological events, and again, maybe because of their other comorbidities, metabolic syndrome. This is a part and parcel of the entire game. We have to be careful. Uh, a point about MELD score in these patients, which I think Subhash wanted to highlight, that uh, MELD does not define the need of liver transplant. It's only a prioritization score. I think this is one line which we can take from this slide. We do MELD in all our patients, but yes, the fact is that MELD does not define transplant. It is therefore prioritization. In our practice, especially those of who are doing living donor transplants, we honestly don't, substantially use MELD to include them over in their waitlist situation. There's a different algorithm altogether. But yes, in a DDLT setting, MELD is very important, and we have to go according to that. And in obese patients, it's again not so easy. A lot of these patients have HCC. We know that there's higher incidence of liver cancer in these patients who have MASLD, and because of their obesity, resection is not so straightforward. We can have other therapies, loco-regional, but yes, a combination of MASLD with HCC is a difficult situation. I mean, you can do TACE or TARE. We have seen that following TARE, there can be significant substantial lung injury, radiation injury, especially if the patient had a higher shunt fraction and your radiologist has not been able to reduce that by maneuvers like embolization pre-TARE. But yes, one has to be careful in this. The selection criteria I don't think are any different. So I'd skip this slide. And in cadaveric versus LDLT, yes, this is an important slide because we all believe that those who are obese and have got end-stage liver failure, DDLT is a good option or a better option because it gives a larger liver volume. And if you have to do living donor transplant, because of the smaller volume of a graft, we may have to do a dual lobe transplant. So this is a point I think which is worth discussing. Is it the right thing? Well, when I was in Ganganam Hospital, I remember the first dual lobe transplant was done in a patient from Salem. I know his name, Apu Chettiar. His son and daughter-in-law, they donated. He was an obese guy. Till date, he's doing very well, but that was 2006 or 7. and after that, the door lobe has never picked up. But yes, that was the first one in the country which was done. Nowadays, there is a trend to do other maneuvers, reduce patient recipient's weight, get a better graft volume, and the surgeons I've been speaking to, they have got some. They always want to like for whatever the radiological volume in the graft, they always have a tendency to increase or decrease based on the requirement because of their excellent technique these days. But 2 points which I think Subhash wants to mention. One is that uh, there is a publication that higher weight, more than 100 kilograms, uh, where the graft weight is low and obesity is there, it does not impair the outcome of liver transplant in these patients. I'm talking about living to a liver transplant, a very important paper which was published sometimes back in liver transplantation, and a subsequent paper where there's emphasis given that if you have a graft volume which is more than 650, perhaps it is sufficient enough to take care of the crisis of the GRWR. Again, this is something which has not been reproduced and not universally believed, but those are the views of Professor Gupta, and I think it's important one can discuss that. So essentially, uh, besides the huge challenge of a small graft in an obese patient who is like 130, 140 kilograms, there are certain unique challenges, surgical challenges. Believe me, this is something which I have been seeing. I know they are obese, they may be 130, 140, but their space in the abdomen is limited. Actually, there's a tight fit because there's a lot of visceral obesity, there's fat in the mesentery, and so on. Their actual retraction is very difficult, and these patients actually have a difficult in the fitting of the right lobe graft. That's one thing. OT setup, yes, you may need a table which is able to, accommodate such morbidly obese patients, 130, 140 kilograms. And as I said, retraction instruments may have to be different. Better airway management, especially these patients who have OSA and all, they may be difficult, may need BiPAP in the post-op period. Hemodynamic instability because of diabetes, autonomic dysfunction, and so on. And as I said, intra-abdominal obesity limits the graft accommodation and mobilization, which is an interesting fact, and that one has to be careful. And also, in this MASLD era, besides the recipient being fatty, the donors often are steatotic. We all see about 50-60%, I would say more than that actually, of our donors who are being evaluated are fatty. And steatosis per se is a different discussion, but yes, a combination of morbidly obese or an obese recipient 100 kilogram plus with a graft volume which is low, GRW on the lower side, and the donor is also steatotic. This is, I think, is a terrible combination. So please be careful. If you have a situation like this, at least the donor should be one which is free of fat, healthy, fit. Post-operative, lot of events, one can just, assume that these are going to be there in any obese patient, and one has to be using renal suppressing immunosuppression, delayed immunosuppression, basiliximab, and so on, everolimus early introduction. Yes, long-term outcome may have a problem because of metabolic syndrome coming up. There is recurrence of NASH in these patients, MASH for these patients, and there is a higher issue of dysfunction of the graft in these. I just wanted to present these two slides in the last, which have been done by one of my fellows. Of the 419 MASH cases who were transplanted in the last 5 years, the comorbidities, you will see that diabetes was there in 21%. Then we had chronic kidney disease in 15% and coronary disease in about 6.2%. But come to this bottom line, I just was interested to note that about 70% of these patients are either overweight or obese. So that is very important. So you're dealing with a very unique group of patients. And this is a patient, actually, he had, I know this patient very well. He was in my different hospital earlier. Then he came to us for a transplant. The recipient was about 130 kilograms. The daughter was very keen to donate, only 65 kilograms. Her graft was pristine, no fat, very healthy girl. Her right lobe graft was 710 grams, which was, reasonable. Remnant was good. But the GRW was only 0.54, which many of us would not agree. So this is like a new trend of ultra low volume GRWR. which is there. She had this. She donated the liver. The gentleman had an excellent recovery. Went home. Is doing very well now. But this is not a message. It does not mean that we should take a patient with a GRWR of such low values. Just in one-off case, I thought I'll show you, not to get scared. But yes, it is possible. But in our practice, we would not like to take such a low GRWR. And in these patients, the mortality actually, I was interested to note this point. You'll see that the first year survival within 30 days was very good, 92%. Somehow the 1 year survival was 85, and then 3 year was even further down. Perhaps what's happening is that the group of patients whom we are using for MASH transplant are elderly, 60, 65 plus. They have more comorbidities. We are very good in tidying up the initial part, but because the baggage of comorbidities is there, you cannot get rid of them. You cannot get rid of their CAD, their chronic kidney disease, their dyslipidemia, and so on. So therefore, we have to be very careful that as a message that if you have done a transplant for a MASH CLD patient and they're elderly, be very careful in your management so that you don't lose them on the follow-up. So there's some complications, and I'll finish off with this. Well, HCC is there. It's just it's a difficult situation, but I think nothing different from what you see in average HCC. So in the summary, yes, it's a complex situation. As I said, obese recipient, low GRWR, small volume, and if it is a situation where the donor is also fatty, then it's a very, very bad combination. And only one message here, that liver in liver transplant can give good recipient outcome if you don't have DDLT setup like in ours in another part of the country, but that's not the best. And interesting again to tell you all, it's a tight fit in a small cavity. Don't consider that an obese guy with 140 has a big cavity. No, there's a lot of fat inside. Difficulty in fitting the graft is there. And yes, those are very sick, ACLF3 and all. We should not consider these patients for liver transplant in a MASH situation. Thank you very much for the hearing. Thanks very much.
Thank you, Dr. Saigal. The house is open for questions. If I may set the ball rolling. So, would your immunosuppression differ in these patients in post-op? If yes, how?
See, what I do is, if they have got chronic kidney disease, that would be one which will make my strategy be different. I will be careful not to have their kidneys going out. Right? I'll probably use a CNI sparing thing or a low dose CNI to start with, and if possible, maybe early on, this big North American trial where I'll use a low dose TAC combination along with everolimus, starting about 8-12 weeks, and then continue it, or maybe a little later on. But I think that's something which is possible. Cardiac, you cannot really do much, but yes, I have to be careful that I control the sugar very well, I control the lipids very well. I don't, especially if I'm using everolimus, their TGs go off very badly, and I have to be very careful that I don't let that happen. And rejection all is similar. I don't think there's different, and I would not use any what you call as antibodies in my induction. I would not use that.
Dr. Sija, please.
Thanks, Sanjeev. I think very nice talk always. I think, and thank you very much for taking care. And Subhash couldn't make it, and you done
I got
it.
the message
Yeah,
yesterday
in the morning,
night,
I
11
know.
p.m.
I know, that's what I'm saying. It didn't look like that this was yesterday night. You've done a wonderful job.
Thank
And
you.
thank you so much for that.
Thanks, Ajay.
My only other thing is about the post-transplant metabolic syndrome, and both recurrent MASLD and the de novo MASLD post-transplant, which I'm pretty sure is a big issue always. Lifestyle interventions are obviously there, but then people always look for pharmacotherapy. There's some data which has emerged on saroglitazar post-transplant, both from Dr. Sanyal's group and also from the Medanta group. Do you have any experience on saroglitazar? And now the newer drugs which are coming in, before this last session, you heard on SAMA, resmetirom, efruxifermin, and other molecules. Do you think they will have some issue using them post-transplant? I think that's the question.
That's an excellent question, Dr. Ajay, and it's actually something which is very, very, you can say close to my own thinking. Uh, First point, the paper from Vedanta and Saugler, I was a reviewer, and giving a disclaimer. It's a great paper, but I don't think we are using it regularly. One of patients I use, but I cannot say right now that evidence is strong enough to use that. I remember we discussed, and in our one of the INASL meetings long time back, we had a de novo versus recurrent NASH, which was we published that. It is a problem, and I think that we have not entered a stage where we can say we have confidently conquered it. As far as drugs are concerned, I am very carefully looking at semaglutide in these patients post-transplant. Problem is that most of these drugs are available for injectable use. The oral one, we have this, one of the semaglutide we use, but I don't know it's so effective. And especially when I used it, I find that patients have got intolerance, a lot of nausea, vomiting. One of my patients had pancreatitis. So I'm very skeptical in using them, the post-transplant patients. And there is no published literature. Probably Professor Sanlal and others can tell me there is no documented strong literature which says that these GLP-1 or GL2 inhibitors can be used in post-transplant period. So I think we are still away from there, and my main emphasis, a very strong emphasis, is to be on the lifestyle measures, and because I know they have what is entity called this, sarcopenic obesity. We published a paper on that in our patients. We found that about 70-80% of patients, if you see them in the follow-up period, they have sarcopenic obesity, and in them, a lot of them have 50% have metabolic syndrome, and then de novo MASLD or recurrent MASLD. So I think these are all things which are still evolving. We use Evion, vitamin E a lot in our patients, but yes, I think we still have more to have in our armamentarium.
I think we are running short of time. We started off 3 minutes late, but then we have, if there are no more questions, shall we? Mic 3, can we make it quick, please?
In the pipeline of the similar question of Dr. Makaria, it is almost inevitable to encounter the metabolic syndrome after doing a liver transplant in those patients who are undergone the liver transplant. What is your main motto in your lifestyle changes, and what are the therapeutic goals in your treatment after liver transplant to prevent or defer it after those transplant patients?
Well, that's a good question. It's a very standard thing, I a huge emphasis on their dietary regimen. We have a dedicated dietitian now in our team, two of them actually. One of them looks after the OPD patients, in patients, and also for patients who are on online consultations, we provide them a dietary consultation very, very strictly these days. Then we have a regimen, exercise, and all, which is very standard, nothing different from an average. Only thing is that pre-transplant, you cannot tell them to do their exercise and all, which we all discuss, but post transplant they can do freely, nothing is bothering them. So therefore, nowadays I think that our patients are much better, much fitter, and they're not more cocooned in their house. Transplant ho gaya, can't move, father mother-in-law feeding them. It's not like that. We make them move, make them run around, and we are doing a good job with that.
Thank you, Dr. Saigal.
Thank you, Ajay, for the opportunity. Thanks a lot.